Perfect. Well, thank you all for joining me. My presentation today is focused on really three parts. So the first part is I chose a journal article that was relevant to my area of study. I'm going to talk about that journal article and really dive deep into what my topic really is and define some terms. Then I'm going to move into what the current research questions are, and then what Dr. Adams and I have decided to do. I included some preliminary code and some preliminary data. So it's called Unveiling the Gaps, Understanding Why LGBTQ Individuals Face Barriers to Cancer Screening.
Very Pride Month of you. I love that.
Yeah, it's very Pride Month. We can click the presentation.
Oh gosh. Is it paused?
There you go.
Okay.
Okay, there we go. Awesome. So you already know my background, so I'll skim through this. The big one, though, is that I'm bisexual. And so whenever I met with Dr. Adams, I really wanted to adjust my focus. So I've really focused recently on clinical trials in orthopedics and fatty liver disease for any adult. That was undergrad and grad school. But I've never done something that was specific to who I am. And I've told a couple of you at this point that I've heard speakers like Dr. Mukherjee when I went to that conference on statistics a couple weeks ago. She's Indian. She had the same kind of conundrum as she was doing biostatistics in the United States. She got kind of in a rut, and she really looked at herself and said, how do I connect who I am with what I do for work? And so she has led India's COVID-19 response since then. I really wanted to take a similar route. I met her later, but I wanted to do a project with Dr. Adams that represented who I am. So that's what this whole thing is about. So first, we're going to talk about the background of queer theory and LGBTQ data tracking. Has anybody heard of queer theory before? Okay. It has data implications, yes.
No. I was like, go ahead. I'm trying to like keep myself awake by doing all this.
Perfect. Second part is we're talking about barriers to cancer screening within the community, facilitators to cancer screening, suggested research initiatives and areas of focus, and then finally my project with Dr. Adams. So first, queer theory. So queer theory suggests that there is an underlying binary nature of heteronormativity. Does anybody familiar with those terms? All right, I define them all in just a minute. But so the binary nature of heteronormativity through institutional practices creates systemic discrimination against those who do not conform to traditional gender roles. So here's the definition of heteronormativity. It's the assumption that heterosexuality, in other words, being attracted to the opposite sex, is the default, the preferred, the normal. And that there is a strict binary between that and being other. Gender roles are roles or behaviors that are considered appropriate to particular genders as determined by prevailing cultural norms. I underlined gender just to make the distinction between gender and sex. Sex is what you're assigned to at birth. Gender is how you identify socially, so just keep those distinctions in mind. The goal, therefore, is to examine the ways that heteronormativity has influenced cancer screening participation and providers' treatment of those LGBTQ individuals. So queer theory has been used to highlight the fact that there is a systemic privilege, unequal power distribution, and oppression that creates heteronormativity. So really, this is not just an idea. This is something that is being felt by the LGBT community for one reason or another. They measured that in my study, and I'll go into kind of some of the factors that may have gone into that. And it is something that people have said that there is quantitative evidence for. And so we'd like to look into that. We'd like to see if there is a healthcare disparity within these communities. So data tracking. All sexual orientation and gender data is referred to as SOGI within data sets that we'll look at today and within a couple other big ones, mainly the CDC, the NIH. They usually have modules that are named SOGI, and so you look in there, and that's where the questions are about how do you identify in terms of sexual orientation, what sex were you assigned at birth, what gender do you identify with, etc. So when did we begin tracking LGBTQ data through SOGI modules? Well, in 2012, Gallup started, and it specifically started tracking LGBTQ population-based data for cancer. In 2017, 4.5% of the United States publicly identified as LGBTQ, which is only represented by a fraction in any study that we look at. So keep in mind that this is, 6 or 7 years old at this point. But that's publicly identified, so we don't know how many aren't speaking up. And then inside of the studies that we looked at today, we're talking a fraction of 5%, usually 1.2 to 2% total of the population being studied as LGBTQ. All of the studies that have been done in the systematic review I'm going to talk about are through specialized surveys that include those SOGI modules. An example is the CDC breakfast dataset, which is what I'm using for my research, which we'll talk about later. They have optional SOGI modules, but many organizations, unfortunately, are not tracking LGBTQ data. They don't have a SOGI module. This includes big organizations like the CDC, Prevention's National Program on Cancer Registry, the NCI, the American College of Surgeons, and the ACS. So these huge, national level institutions are not tracking. They may be tracking, how do you identify whatever as part of their general survey, like in breakfast, but when it comes to cancer data, they're not connected. And so all of these things are cross-sectional. It's very hard to link a individual data point back from like the general survey to cancer to their LGBT status, because it's all de-identified. And so unless the CDC is doing something like the RFA is doing, where they're assigning a unique identifier, there's no way to backtrack who was being surveyed and when, what they identified as. So it's just interesting that none of these data sets have a SOGI module, which leads to very limited cancer data. Despite all the things we're going to talk about on the next slide, most organizations, most surveys don't track it. I really searched to find the CDC breakfast data set before we started the program. So LGBT and cancer. LGBTQ have the highest rates of tobacco and alcohol use, and that's by this study, but also many others found that very interesting. Both of those are known contributors to elevated cancer risk, including these type of cancers. Two of them are infectious, mainly cervical, which is caused by HPV. Anal cancer is also caused by HPV and H. pylori. There are cancers associated with tobacco and alcohol use that are not considered infectious, and so I didn't specifically look at them, but breast, endometrial, lung, prostate, and colorectal. The journal article I chose is called Barriers and Facilitators to Cancer Screening Among LGBTQ Individuals with Cancer by Haviland et al. 2020. The journal impact factor is 1.9, so it comes from a pretty good journal, and it's really focused on nursing. You'll see why in a bit, but there is a trend towards this idea that maybe physicians aren't the best person to be handling these type of sensitive situations. You spend the majority of your time in the doctor's office with a nurse or a medical assistant or a physician's assistant. And so if you're trying to make somebody feel comfortable enough to tell you about their sexual orientation, maybe it starts with them and not the physician who you spend 5 minutes with. So we'll talk about that in a bit. The methods for this paper, it was a systematic review. Systematic reviews are basically summaries of what's in the literature at that time. So from 2008 to 2018, how many articles matched their criteria? Here's the criteria. It came from one of these 3 databases. They used a combination of LGBTQ search terms from 2008 to 2018. In English, published in the United States, they excluded HIV studies, which is very important. 75% of the funding from the NIH that is focusing on the LGBTQ populations is going to HIV research. But whenever people have HIV, that comes with its own facilitators and barriers to disclosure and to screening. So they excluded HIV studies, too many confounding variables. The sample size ended up being 12. They screened hundreds of articles. They got it down to 45, and then they narrowed it down to 12 that actually had available survey data for them to analyze and met the criteria. Then they followed the integrative framework, integrative review framework. It's kind of like PRISMA or Cochrane, if anybody's heard of those guidelines, and the multi-level influences on the cancer care continuum, or MICCC framework. Here you go. So this is the framework. They basically said that if they're going to analyze factors that are contributing to stopping people from being screened or encouraging them to be screened, they're going to fall within these categories. So the factors are either going to be individual patient level, family and support level, provider and team, which is like the hospital, the physician, etc., organization and or practice setting, environment, community, health policy, and national health policy, which I grouped into one category. Here's examples of each of these. You'll see them in the following slides, but if we're talking about individual patients, which is what the data I have is really about, we're talking about biological and socioeconomic factors, ethnicity, race, etc. So what are the barriers to actually getting LGBTQ to be screened and be treated for cancer? Well, at the individual level, number one is gender identity and expression and sexual orientation. So that was interesting, goes right along with my topic. Whether or not you are comfortable enough to disclose is going to serve as a barrier to your treatment. So if the doctor doesn't know that you are identifying as one of these groups, then they can't identify you as being high risk. HPV is transmitted through vaginal fluid and through feces and anal fluid, mostly through women who have sex with women, men who have sex with men. If they don't know that you are in one of those categories, they're not going to give you the educational materials that you need. Additionally, the doctors may not know the educational materials, which is on the next slide. But also, racial and ethnic identity influence the perceptions of whether or not your provider is going to care about that. Your socioeconomic status, people who were less educated or made less are less likely to disclose. Provider and patient knowledge gaps, poor physio reaction, and lower educational attainment. There was a subsection in this where they studied the likelihood of cervical, colon, and breast cancer screening among LGBTQ, and what they found is that if you don't identify with if you're gender nonconforming, if you're transgender, bisexual, if you're a minority, you have lower education, especially if you're a woman, or if you're financially unstable, then you are less likely to be screened for any of these cancer types. You don't feel comfortable in the clinic. If you are one of these three categories, you especially don't feel comfortable whenever you're talking about pap smears or anything that involves the female anatomy. And so you're not going to get screened, and therefore your rate of cancer is going to increase. And then this one, Black, lesbian, bisexual, and queer women reported negative screening experiences associated with perceived discrimination. So they, because of one reason or another, did not disclose to their physician. They just felt like the physician was either going to be homophobic or racist or did not want to open that door. More barriers. So for screening, there are a lack of LGBTQ guidelines. So we don't know exactly if they should be treated any differently compared to non-LGBTQ patients. You would think that if you are at a higher risk because you are having sex with the same sex, then you would be at a higher risk and therefore you should be treated differently. That's currently not how the healthcare system is focused. You're treating everybody as the same. And you're not asking. So physicians don't ask questions about gender identity and sexual orientation. The knowledge of existing guidelines is even more of a gap. Physicians don't know, so how are they going to tell their patients? And patients don't know. I had a conversation where the person who actually I had this conversation with my grandmother, she didn't know how frequently she was supposed to get breast cancer mammograms, which is very interesting because her mother died of breast cancer. So there's clearly a family history, but the doctor didn't ask. My grandmother hasn't had insurance coverage, so her socioeconomic status was influencing that. It's just very interesting that she didn't even know about the screening and how often she's supposed to get it. Specifically, there's a lack of knowledge about the HPV transmission, so people don't know that it's spread through the different ways I talked about, and they don't know if they're at risk to begin with. For psychological and coping related factors, there is a psychological distress factor that stops people from being screened. Talked about transgender people, if people don't conform to a specific gender, they have gender dysmorphia. And so any conversation really about their body like that is going to make them uncomfortable and they're not going to want to do it. There are ways around this though. People have proposed maybe letting people assess themselves, making sure that their physician looks like them or is the same gender as them, anything that can make the patient more open to these screenings. And then women who are open about sexual orientation to their providers were actually less likely to know about HPV's role. And so here's another example where, these women actually told their physician that they fell into one of these groups, but for some reason they did not get the education on HPV status, were not offered a vaccine, they had no idea that they were at increased risk. And then finally, moving on to the provider team. So the provider, the physician, and their clinical team lack LGBTQ specific training. They don't know how to deal with sensitive topics like that. They don't know how questions about the body and physical characteristics are going to affect people with gender dysmorphia. They have poor communication. This was reported by the patients in one of the studies that the doctors had poor communication and teamwork skills, which led them to be less open to discussing their sexual orientation or gender identity and being open to the physician about their healthcare concerns. Assumptions about SOGI status, again, if you don't ask, then you don't know and you can't provide information. Lack of knowledge on the anal pap test, didn't know that that was an option, but you can do it yourself and it's much cheaper. So not only do physicians not utilize this option, but most people don't know that that's even there. And then fear of discrimination from their physician, again, depending on their experiences, what you perceive them to be like as a person, they don't want to disclose. Organization, practice, community, environment factors, perceived lack of acceptance in the current healthcare delivery system. That was coming from a study that asked LGBTQ populations how they felt about the current healthcare system, and they felt like they were not accepted, that there were heteronormative assumptions in the system, that they were not being asked, and that there was fear of discrimination. Policy, most published guidelines are for cisgender individuals. Cisgender means those whose gender aligns with their birth assigned sex. Policy hurdles for transgender patients is also a problem. So if you have a transgender patient and they are requesting a procedure that is not covered by insurance because they are transgender, were not assigned a specific sex at birth, then they can no longer get healthcare treatment, and usually they have to have an advocate. So their physician will have to speak to the insurance company or have to speak to another funding source to get that procedure done. In some cases, yes, we're talking about gender reassignment surgery, and others we're not. If you transition to female and you contracted HPV, then you're going to need treatment, especially if it develops into cancer. But if you, for some reason, were barred from that because you weren't female at birth, then somebody's got to go fight the insurance companies on that. There is no policy to protect against that right now. Facilitators. So these are some of the good news. So for individual patients, if you match the patient with their physician or their caregiver by race, ethnicity, social position, life experiences, or gender, they feel more comfortable. I can relate to this. My doctor is a bisexual man, and he has a similar background from me, he's from Florida, et cetera, et cetera. I feel very open with him. I did not feel open with my previous provider, who is an older guy from like Oklahoma. So I switched. I didn't even realize that's what I was doing because I just, I moved, but definitely these things help. For transgender individuals, if they have feminine gender expression, that seems to allow them to be more open to pap smears and screening procedures. Personal importance of routine appointments, like if you're just one of those people that likes to keep a schedule, that helps with adherence to screening for cancer. Being aware of and controlling your sexual activity, we're talking about protection and contraceptives, that'll help. Previous findings on screenings seem to scare people into getting screened more regularly. Having insurance is a big factor, more education and higher income, family history of cancer. My grandmother is the exception because she doesn't want to talk about it. And then positive role models and a support system. If you have people in your community that look like you and have done this before, then you're more likely to do that too. Age is not a factor. So a lot of people believe that the older you get, the more you care about your healthcare. Not so much in these studies. Older LGBTQ individuals did not have a higher screening rate than younger LGBTQ.
Do you think that's kind of like a, well, I made it this far kind of
Yeah.
situation?
That's how my grandma is. So maybe this has nothing to do with their gender identity or sexual orientation. Maybe this is just something else, a separate factor, not age, not depending on social status. They just either think that they're healthy because they've lasted this long, or they're afraid of never. So, not sure. That needs to be studied more. For a provider and team, it'll really help if you don't assume social status. And the way you get around this is, it's kind of awkward to ask somebody, hey, are you X, Y, and Z?
Are you gay?
Are you gay? How do you identify? It's very hard to do that. Instead, and I was taught this by a physician, you ask open-ended questions. So you don't want to directly call somebody out, but you want them to start a conversation with you and feel comfortable enough to disclose that. That's how my doctor did it. And then you need to be knowledgeable if you're a physician seeing people like this, which is any physician. You just need to be knowledgeable of same-sex sexual transmitted diseases, health and risk factors, et cetera, so that if you encounter a patient like that, you can give them the appropriate patient materials. It may be rarer than some other cases. It may be something completely outside of your field that you never expected to learn, but you do need to know how to deal with those patients. Shared demographic and socioeconomic status. Again, if you are in some type of congruence with your physician that makes you more comfortable, it's great. Gentle touch. So people with gender dysmorphia said that the thing that really got them was how invasive the touch was whenever they would have to be screened for breast cancer or for cervical cancer. They would rather a very gentle touch, and they would rather the physician acknowledge the fact that they are about to touch them and go very slow. Because again, gender dysmorphia has a host of psychological problems, and that's very hard to deal with unless you are in a very safe space. So that's what they're trying to create. active listening during the procedure, allowing for self-collected pap samples, especially with the anal test, and then previous positive contraceptive or screening experiences with the provider. If the provider has been good to you in the past, you're more than likely to continue with screening procedures and follow up in the future. Then feeling welcome by their provider and having their partner welcome. So whenever you bring your partner to the clinic with you, if your physician acknowledges them, tells them hello, talks to them as well while they're talking to you, just like you would with any old heterosexual married couple, that helps people become more comfortable. This was very interesting. 2 studies said that people within the LGBTQ community would rather be seen by a PA or a nurse practitioner because they give them more time and more attention than a physician would. Is that true? Maybe. Makes me kind of question my practice, but
No, I was gonna say for the HIV patients, that was exactly what I mentioned to Professor Baker.
Yeah.
That they're more happy chit-chatting with, and also the nurses spend more time with the patients than the doctors themselves. So the physician assistant and the nurse practitioner and the nurses are probably more engaging and asking questions like, risk factor in the family, have you been doing this? And, just a general conversation, but then the way they say it and so calm and soothing, not criticizing, not that way. So I feel even for the HIV patients, they're more likely to feel kind of calm and protected and secure with that, the physician assistant and nurse practitioner.
that's a great point, and I've seen it. That's why PAs, nurse practitioners are so popular nowadays. It's because they take that time and effort burden off of the physician. The physician only has to see you, at certain visits for a certain amount of time to improve efficiency. Yes, but I mean, if it helps, then I think that's great, because the number of people who are being hired in those roles is very quickly. And then finally, education on anal examination, and that's self-anal examination. You can self-check for signs of HPV infection. Knowing that is very important, especially for gay men. All right, lesbian and bisexual women and transgender men are 4 times more likely to be screened when recommended by their provider. So if the provider knows that you fall into one of these categories and are at higher risk, and they recommend that you get screened, that increases your chance of actually falling through on that by 4 times. So very important to just keep a dialogue with your doctor. And then policy. There are states with legal protections related to SOGI populations, and they have an 8% higher likelihood of having colorectal cancer screening. So maybe not all cancer types, but at least along colon cancer that's being studied, just having those legal protections increase screening by 8%. The other ones are not being studied, so I don't know the rates on those, and some of them don't have specific protections. So we don't know yet, but it seems promising. Suggested research initiatives at the bottom of this paper. So the first one is specific guidelines on LGBTQ health and clinical treatment. I think this would be really helpful. I gave a presentation on consensus statements. If there was something like that for doctors where maybe they got the expert opinion of people who specialize in treating the LGBTQ, that would be really great, so that you know how to treat them, how to phrase your questioning, how to not make them uncomfortable, because the second they feel uncomfortable, they're going to shut down. Education of LGBTQ patients on same-sex risks. This is getting better. Did everybody here take some type of sex ed when they were in elementary school?
High school, maybe some college.
I think selling my bed.
Yeah.
Generous.
I had mine after 5th grade, before 6th grade.
Yeah, I think middle school where it
7th.
starts, 7th, 8th, and yeah.
That's when they tell only the girls about periods, but not the boys.
We watched
Not
the
allowed to show them the tampons we
Yes.
got.
We had a high school version, but they came in because we had like a high rate of something in our district. So they were mandated to come and give us tests and also educate us. It was some STI that was really high in our district.
What grade? What grade? High
School,
school?
I had to be like a junior
Okay,
in high school.
I was still imagining middle school, and I'm like, oh my god.
No, we were like juniors or seniors, but I mean, it was great. Like, I think that was like the best sex ed that I had, way better than middle school, because it was very open to all, if you were gay, lesbian, straight, whatever, it was, we did it all, it was great.
That's great. I did not have that experience. We were given a video, and teachers were clearly uncomfortable about it, and there was no mention of sexual orientation or gender identity. Now, went to school, this must have been like 15 years ago. So hopefully it's changed a little. We have to ask the people at that level now. But so there's a big debate over whether parents should be having these conversations or whether the school should be doing it. I think that whoever's doing it needs to do it right. And so having education at that level for LGBTQ people would be great. Keep it anonymous, keep it general, but just say it. And then if people want to follow up with their guidance counselors or healthcare professionals, then they can do that as soon in their life as possible, I think. Policy banning discrimination based on SOGI, physician training, and active data monitoring, that would really help. If that was just like a national ban, if physicians were all trained specifically, and some medical programs are doing this now, I've seen a couple like at Wake Forest, they tell you specifically how to talk with these populations because they know they're at risk. And then active data monitoring, so making sure that you are actively tracking sex and gender and sexual orientation and following these people longitudinally just like any other population, that would be great. Right now, Allscripts and Epic, I don't think they differentiate between sex and gender. So
They don't have that.
yeah, unfortunately.
I think you're talking about EMR,
Yeah, the EMR.
No, they're not there yet.
Because I have had a case where a physician met with somebody and called them the wrong thing when they clearly were
Obviously, like, yeah,
obviously like they were talking about it, they corrected them, and then the physician continued to call them by the wrong pronoun. Because could have been personal bias, but also the EMR said one thing that was wrong. And I saw that on the records too, and so that's very unfortunate. Hopefully we can fix that, also improve data quality. LGBTQ specific research initiatives and funding, not just HIV. Like I said, 70% of NIH funding right now is going towards HIV studies, which is great, but only 1.8% to cancer. So that needs to be fixed. Additional research using larger scale studies to assess cancer screening barriers and facilitators, understand providers' lack of comfort and their lack of knowledge with those screening procedures, and then cancer screening data among LGBTQ populations to lead to the identification of improvement areas. So that's really kind of the inspiration that we chose our topic for. So my current project is focused on assessing temporal trends 2014 to present in HPV vaccination, cervical cancer screening in relation to cervical cancer development, subgrouping by SOGI, non-SOGI, and then subgrouping them urban versus rural and racial and ethnic groups. We believe that there will be a difference between SOGI and non-SOGI, just based on the literature review. We also believe that urban versus rural access to healthcare is going to be a big player in this that was not evaluated by the previous studies. Racial ethnic group, we're expecting a difference, just based on previous literature. Your question?
Oh, no. It's because I don't have my glasses and I thought it was like temporal, which is like the brain, but then I realized it's like time.
Yeah.
No, it is the brain. I think it's like right here.
Yeah.
All right. So cervical cancer. It's a cancer which is just a massive uncontrolled cell growth that originates in the cervix. The cervix is right behind the vagina. It is number 20 on top cancers list with 13,820 cases per year as of 2024. New cases, so we're talking about incidence. And then 4,360 deaths per year as of 2024. It's slow developing and it's preceded by dysplasia, which is abnormal cell growth. This is what they're checking for when you get a pap test or the anal pap test. And we'll zoom in a minute, but it's basically a very specific section of the cervix that's accessible clinically. There are cases where it can develop closer to the uterus, but those are more rare, and there are specialists.
Just a question.
Yeah.
So HPV is caused by an infection by some bacteria or virus, right? So is it the virus that causes it, or is it once left untreated, it causes cervical cancer? Like what?
So the virus will infect cells within the cervix. So through sexual intercourse, HPV will enter and get stuck in the cervix. Once in the cervix, they'll attack specific cells. The virus will infiltrate, will take over the cell's machinery, and it will cause unnormal cell growth. It'll stop any stopping procedures within the genetic code. So your cells just start to rapidly deteriorate and duplicate into a mass. So it's the virus that caused the cells to dysfunction that causes the growth called dysplasia. And if dysplasia goes untreated, it can develop into tumors.
Okay.
Those tumors can either stay localized, and there's a big difference in survival rates between localized to the cervix, or they can metastasize into the uterus, into other parts of the body. At that point, your rate of survival goes down.
So HPV doesn't just increase your risk, it directly
Oh yeah,
causes.
it does.
Okay.
Just because you have HPV doesn't mean you will get cervical cancer. But HPV does cause it by causing the cell system's malfunction.
And it's also just, it's a leading cause. You can also get cervical cancer with,
When you're born.
with birth, natural dysplasia. It doesn't, I mean, it's a lesser risk. It's a existing risk.
So I think on the next slide, it's like 90% of cases are associated with HPV infection. 10% are you got it at birth or just normal development of cancer. Which cancer can happen like this anywhere if there's a mutation, when the cell duplicates, something gets blocked and the cell is no longer stopping to divide whenever it should, turns into a tumor. That's why a lot of people, I want to go into oncology, a lot of people ask me if there's a cure for cancer that is out there somewhere. I don't think so. I think there's not one cure. I think there'd be hundreds of cures for each individual patient. It's just too frequent. So there are two types of cervical cancer. The first one is squamous cell carcinoma, which is 90% of cases. It develops from the ectocervix, which is right here. It's the part of the cervix that's closest to the vagina. And then there's adenocarcinoma developing from the endocervix, which is closer to the uterus. The spot where the dysplasia will begin is at the squamocolumnar junction right here, which is kind of in the middle between the, down here, the middle between the endo and ectocervix. So one question is, which one is easier to classify clinically?
Well, if you're doing the pap smear, wouldn't it be when you're doing it through the vagina, that way you know exactly how the cells are?
Mhm.
But in case you missed it, then if it was in the middle and above, that would be very difficult.
That's true. So the further,
Closer to the wall.
Closer.
Yeah,
closer to the vagina is going to be more accessible clinically. Physicians can usually access the squamocolumnar junction, but if it has spread to the endocervical canal or beyond, they're going to need a more advanced test to catch it.
Yeah, and I feel like at least from what I've heard with like women friend, it's kind of like the procedure itself is just very invasive and kind of like it could be traumatic for
They
like
don't numb you.
right, it could be traumatic, especially for women
and yeah,
who have had like a history of sexual abuse. Like this just like
scary.
yeah, scary. So I
And painful.
right.
And I think it also, like, for anybody, once a doctor kind of tells you that, this is something I have to do. And I don't, like, most of, like, the way I see it is when my doctor tells me that, listen, this is part of the physical exam and we as doctors have to do it, and there's a female nurse present. So then there isn't going to be anything that's like going to be scary. And then, because sometimes a nurse is there and sometimes they say the nurse is not there.
They all are required to have a chaperone.
Yes.
Right.
So those things, and then when you said the doctor saying that, I need to do this and I'm gonna be, I'm wearing my gloves and I'm gonna be very careful, just those words can kind of
Right.
calm you down.
I also think that's new,
Oh, yeah,
like
yeah,
saying exactly what they're gonna do in the moment, in my experience, is new, like.
yeah,
Right.
But
yeah.
like the warning you.
Like you actually have to tell them, like, I have a history
Yeah,
of stuff.
It depends on,
before they
I
play.
think, the person you get, whether they are gonna be
Yeah.
like, okay, now this is what you're gonna feel, rather than just like
Yeah.
going for it.
Or if
Yeah.
it's like my gynecologist's office, which has like an angel statue facing where your stuff is.
That's a lot.
And then there's this red spot, I don't go there anymore. There's this red spotlight right where the business is gonna happen. And it
That's
feels,
scary.
and then he's got like revival music playing in the background.
That's a lot.
No, my doctor is like very, she's Afro-American, she's amazing
I
and.
have to get your contact after this.
Yeah, she's, and then she will always, like, she'll always say, even though you don't have a risk factor, I will do it this one time. And then if you're clear, we'll do it only once every 5 years. So she will let you know that this is because it's not because of your risk factor, like there's no risk factor, but because it's your physical exam, and if you're clear, then I will only do it once in 5 years, or whatever is that Prisma Health mandate. But then, like you said, she says it, she's like, listen, I need to do this, so we'll do this, and then there's a nurse present, and the nurse is like, no, we are not going to, like, we're talking to you, like sort of a verbal consent. like, we're gonna do this, and then this is gonna be, and then you'll get a result or not, whatever. So I feel like what you said is very, very calming, like, okay, this is only once in 5 years, and yes, at least they tell you.
Yeah.
It's not like as if I marked there, you know, because my grandparents, I have no idea, like you said, what their whatever was, nothing, because they were in India. So I don't know anything, whether they had heart problem, I'm just doing things by race, like, okay, my race has a heart problem, blood pressure, you know, those kind of things, which is common for other races, but I have nothing I know. So those kind of things when the doctor's actually explaining, even though she's a female doctor and I'm a female, and telling me, it kind of like, okay, it's only once in 5 years. Yeah, it's like, okay, I can do this, it's only once in 5 years. And she has a nurse who's also a female nurse, because I think last time she was like, are you okay, I have a male student who's also studying to be a gynecologist. If the male student can come in, I was like, no, I would not be comfortable. I was like, I know you're training doctors, but I don't feel comfortable if there was a male doctor or a male resident with you. And she was like, I completely understand. And she was like, okay, I'll get a female nurse.
Yeah, I'm gonna get that contact.
So I felt like, you know, somebody who discussed it there, because I know as doctors, they don't, I'm not gonna be rude, but I'm saying as doctors, they may not understand the sensitivity. Because then they're like, oh, I'm a doctor and I have to train my resident doctor, so they don't understand some females may be shy. I mean, okay, he may be very professional, but I would not want a male nurse or a male.
Well, you know, you raised your whole life to believe, you know, you're not supposed to spread your legs.
Yes.
Anymore.
And then all of a sudden, yes, and that resident doctor was also an Indian, so it's not like it's a race thing, it's just a gender thing for me. Because she was like, you know, I'm like, no way. I was like, it doesn't matter, could I just have a female nurse? And she was like, that's perfectly fine. But the fact that she declared it, she was like, I do have this resident doctor who's learning.
Also is actually understanding.
Yes. Yes.
They're not rummaging around you like they're looking for the last premium.
But you know, not to turn this into a focus group discussion on gynecologists.
But yeah, I agree, because she was very like, because the fact that she said it's only once in 5 years. So I was like praying, like, God, please, there should be nothing.
Yeah.
My report should be clear, but like I'm saying, it's nice, even if she's a female doctor, to say those words, like, just calms you down.
Well, thank you, and we're gonna get back on
No,
that.
definitely.
Yeah, but let's go ahead and get back, cause I don't wanna derail your presentation
You're
too
good.
much.
I built this.
Because we will talk all day about our woes with gynecologists if we don't move on, so.
Okay, well, 3 small points. One, interestingly, primary care and family care physicians are doing a lot of pap smears, a lot of mammograms.
Yeah.
It's not just the gynecologist.
No.
So it happens very frequently, which is, I think, is a good trend, because usually you're more comfortable with your primary care and your family care.
Yeah, you know them longer.
You know them longer. Second, I was one of those trainees once, and I was very fortunate, because I'm a man and I have no idea what a pap smear is like. I was very fortunate to have that experience, and I saw how uncomfortable it was. And so I definitely recognize that when you're doing something that's sensitive and invasive, you need to make sure that you are talking and that you are creating a rapport. And so I love the shift, my third point, towards more personalized and individualized medicine. Doctors may not like it, but every survey study that has come out says that patients want to be more involved in their healthcare plan. Patients want to be more involved in clinical research planning. Patients want to be advocates for themselves, you know, and I think that's great. So on to their interventions.
Oh, yes.
Awesome. All right. So HPV, there's many types. The dangerous ones are HPV 16 and 18, which lead to the development of those precancerous regions. 6 and 11 cause benign lesions or warts on the skin, and a couple of other non-cancerous things. They spread through sexual intercourse. It is a virus, and you test it with a pap smear to detect the cancerous cells, as we discussed. Vaccination is available within certain age groups as of 2009. It's most frequently diagnosed to women aged 35 to 44, I think, with like a median around 50. And then their 5-year survival rates depend on if it's localized to the cervix or if it has metastasized. So just keep that in mind. So what is my current project actually about from the background? The CDC has maintained this annual 1988 to present, behavioral risk factor surveillance system, or BREFIS. BREFIS is this huge data set. Talk to Grant about it. They do an annual survey. It's cross-sectional where they call people, or they will they'll call them on landline or cell or one other thing, but they will get their individual patient family history, demographics. There's like 26 modules in the BREFIS handbook that they're asking patients about, or just people. It's in all 50 states and DC and US territories. It's good for public health, and it includes individual level demographics, health related risk factors, chronic conditions, and preventative services. So that's vaccinating, things like that, screening. They also have incorporated an optional SOGI module that was introduced around 2014. So SOGI is the sexual orientation and gender identity module. It's only been around since 2014, so the data is a little bit iffy, but at least they did it, even if it's optional. Not all states do it though. Here are the questions. So the first survey question, this will look familiar, like the code book we looked at the other day. The label, sexual orientation, coming from the SOGI module. Column number 639, numerical variable, SAS variable name, which is really this variable name. This is SO male, and this is the question that they're asked. Which of the following best represents how you think of yourself? And then here are the numerical values that are encoded to represent these value labels. So this is what I meant where like, I'm gonna have to re-encode pretty much all 400 variables of the BREFIS data set, or at least the ones I want, so I'm trying to narrow it down. But you can separate it into non-SOGI, 112,000 data points as of 2022, or the LGBT answer, so gay, bisexual, something else, and then you'll have to account for, I don't know the answer or refuse. So they at least are asking, and this is for males, they're asking males if they identify in this way. And then they ask the same question of females, exact same thing, except the variable name is SO female, so I can separate it by gender as well. They're asking you if you identify as transgender. They ask you about your sex at birth earlier in the survey. And those are the 3 survey questions. So it's very, very easy to just throw those in there. Luckily, they started that in 2014, so I'm able to do a temporal analysis. The data is stored as one of these ASCII file types. I've never dealt with that before, or SAS transport format. I don't use SAS that frequently. So I used ASCII, I read it in, and you have to read it in with these corresponding column links. So you can think of this ASCII file as just kind of being a combination, it's like Excel, but the columns have different values. So you need to map each of those values to the column to actually get the column information out. And so for each of these variables, you have to tell R or SAS, whatever you're using, the length of the columns. 2022 had 445,000 records. 2023 has a big release yet. Should be any day though. Let's see. Next, 471 columns. The code books and general survey information are provided as PDF and HTML files, which is unfortunate. If I wanted to read the code book and to re-encode my data from numerical back to its actual values, I have to like copy paste from the HTML or the PDF, which is very annoying. Here's some code, since we're all a little code deprived recently. So this is in RStudio, coding in R. I loaded tidyverse for wrangling, read Excel to read an Excel file. That was just for the column links because it's an ASCII file. Data Explorer is the solution I said to Dr. Olatosi, I think yesterday, where he's talking about something that can generate descriptive statistics for you automatically. If you give Data Explorer a data frame, it will detect numerical versus categorical and generate the appropriate descriptive statistics. So it's really nice for when you have a bunch of data. Here is being used because I nest my folder organization, and I basically have to tell it that within my working environment, look in the data folder and use this file. You can't do it directly. Reshape 2 is something I needed to get the data into a format that could be graphed. And I do have one graph that I'll show you. From here, this is all for one individual file. So I'm just reading in the file widths from BREFIS or an Excel file, and I'm telling it where to start the column and where to end the column. Yes, did you have a question?
No, there was a hair in my eyelash.
Okay, perfect. It's calculating the file width, it's reading in the data. Here's the data ASCII file, here's the widths that it defined, and the column names are also widths. Then when you read that in, it gives you a normal data frame. I'll show you what it looks like in a second. The only thing extra that I'm doing is any columns that are completely NA, drop them up here. Here's the function that I wrote to do this. iteratively over all of the files because I have 2014 to 2022. And I basically need it to load in the data set, that data set's corresponding column links, read it in, drop the NAs, put it in the data frame, and move on to the next one and do the same exact things. I also incorporated a couple other steps in here. So I specified my variables of interest. There's 473 variables. I only need like 25 to 50 of them. So trying to keep it clean. I assigned a row number to make an individual unique ID for every entry because I'm combining multiple years together. And then I am assigning the year as its own individual column because that wasn't in there originally. So if I'm going to read in 8 different years, I need that specified so I can subgroup later. Here's the data frames, very clean. Everything is encoded, unfortunately, which is great for if I'm going to do an ML model, which we are. Dr. Adams and I submitted 2 programming papers, one on machine learning, one on GIS. But everything's represented as numbers. So your number 1 state corresponds to, I think, like Arizona, the month January, etc. So I'll have to do a lot of data cleaning steps, but at least I do have everything in one data set at this point. And I think it's 400,000 observations per year for 8 years. So that's how many total I have. Here's my current problem that I discussed at the beginning of this. 2022, all the variables of interest are in there. These are all the variables I want. The red ones are related to cervical cancer or SOGI. So this is cervical screening, pap smears, HPV vaccination, the SOGI module questions on orientation and gender. These are relating to whether you live in an urban or rural environment. And here's race and ethnicity. Some of these have been calculated out by the CDC to just like conglomerate into general groups and to clean it up. And what I found is 2022 is great. Go to 2021, I start missing some things. I go to 2020, I'm even missing more things. And it got progressively worse. As I go back to 2014, the variable names are not present. And so if it's red, that means it's not in the data set when I want it to be. If it's blue, it's there. It's because the variables were renamed throughout the years. And so I'm having to go back and figure out which variables from 2021 and 2020 are present, but are named different than my 2022 variables. Map them together because I really do have a complete data set for a lot of these years. They've just been mixed up because the CDC decided to change things up. So that's fun, and it's going to take me some time because right now I've only got 3 years done. I then have to incorporate the following 3 years, going back to 2017, and then finally going back to 2014. It's going to take me some time trying to find the best computationally efficient way to do this because there's 4 or 5 million data points, 20 to 50 variables of interest, depending on what Dr. Adams wants to focus on first. Our intent is to do descriptive analyses first, by the way, just to look and see if there are rates that are different between SOGI and non-SOGI, rural, urban, etc. Then we may incorporate the full gambit of demographic and socioeconomic factors to do some regression modeling, determine risk factors, etc. But that's probably a month away. So that's the current problem, and that's all I want.
Oh, very nice.
Thank you.
I don't think I think I might have missed it when you explained what queer theory is, but what is that?
So queer theory is that whole idea between heteronormativity. It's saying that heteronormativity exists, that people assume that being attracted to the opposite sex is the norm. And that assumption creates discrepancies and disparities whenever you're talking about how people are treated in our system. So that is the whole queer theory. And they've connected that with cancer. So not only is there a systemic bias that people are straight and people are cisgender, but when it comes to healthcare, that has real world implications because questions are being asked, information is being left out, and it's leading to an increased cancer rate. So queer theory is a whole concept that applies to many different industries, but they have adapted it to cancer.
Thank you.
Yes. I have a question. So it seems that HPV, when targeted to practitioners and like which groups are most at risk, it's men who have sex with men, women who have sex with women. But let's say that there's a client or a patient that's non-binary, and maybe it's not so clear like what their orientation may be given the intersection of their gender presentation. How would you go about presenting like what they're at risk for, if maybe that's something that they don't want to disclose, or maybe they're not too aware or like keen on like different gender representation or expressions.
So how do you assess risk for somebody that's non-binary or
Yeah.
non-conformative? Right now, you can't. That is its own group. And there's no data, nobody's tracking, even within these survey models, there is what? I don't know, or something else. And so there is no question for non-conforming people right now. I think that needs to be its own category. As far as,
Perhaps it was in the transgender, I think it looked like there might have been like 500 people measured under that category.
I noticed that part, yeah.
no, I don't know.
Gender
if you-
non-conforming.
Number 3.
Yes, transgender, gender non-conforming.
So I don't know, that's small capture group, it doesn't get much, if any, of the larger population of that.
I would separate those two,
Sure,
because just because you're gender non-conforming doesn't mean you're transgender.
right,
Yeah, you could just be gender non-conforming.
Right.
There.
And then the other thing, sorry, you go ahead, Namasha.
No, okay. Yeah, this is something that I'm sure like you and Dr. Swan are probably talking about. But thinking about, well, like a lot of like terms were not as mainstream in the past as they are now. So people may have like actually been like, if you ask them in 2014 and weren't like familiar with terms or comfortable using, it wasn't like normalized. Like, it doesn't mean it wasn't there, you know what I mean? Like, I feel like there's, or even just like the amount of discrimination, not to say there's not discrimination now, but going back in time usually doesn't help.
Correct.
So like the amount of discrimination people are facing varies a lot through time and like space. I was like, I don't have a like thought on that, it's just like, I know you know.
around those identities.
Yeah, so like, yeah, I
That's
I
a
don't know
great
if you've
point.
like thought about like how you're gonna like deal with it or think about it or just like talk about it in your paper.
It's something we're definitely gonna have to talk about, it'll be a big point of discussion.
Yeah, that makes sense.
Since it's a temporal analysis, we have to discuss the changes that happen every year. We need to discuss the legalization of same-sex marriage, we have to discuss how the vocabulary has changed, all of these different factors are gonna influence whether or not people report. And that's really the purpose of our paper is, we're looking at, because there are papers out there discussing cervical cancer, HIV screening disparities among this community. There are not papers out there discussing the temporal effect. So how has the rate changed since 2014? Hopefully it's gotten better. But if there's a very, very small number of people, coming out and saying what they are in 2014, then that's gonna be a big problem. We'll see that in the data. Because we'll go from thousands of people saying that they're gay or transgender to a very small number. So can't really count for it.
Yeah,
You just
no,
have to
that's
talk
what like,
about it. Yeah, it's great.
I have a quick question, if possible, just before I get on the plane.
Oh, yes, sir.
Oh, cool. Great presentation, and I'm so excited for all the work you're doing. I'm doing work in the SOGI arena too with HIV, as you might imagine. 3 things that I wanted to point out, just to save you a little bit of pain. Yeah, I'm not sure if you've looked each time they make a change to a question in any of those surveys. They add that to the documentation, so you might want to go back and just create a table of what question changed and how it changed. And then I think a challenge for you that could be phenomenal for the field is, this is a classic problem we face when we pull births data together over years. If you can, and this is just another hint, after you do the first 2 papers with Dr. Adams, if you can solve the problem for future users of births, where you create an algorithm that will help them scan and identify questions that changed by year and which ones match the most, you would have solved the headache that you're just going through right now for future users and current users. And I guarantee you that paper will catch a lot of attention because this is a lot of pain. But like I said, this is just an idea that I'm throwing out. But I wanted to know if you've gotten that sense, and I know Bruff's documentation is a lot, but like we discussed in class, and by the way, you're just highlighting all the things we discussed in class, the data dictionary, understanding the documentation, is critical before you start any of those analysis. I'm just curious if you found that to be helpful to help you solve your data truncation problem based on question change.
Yeah, 100%. Perfect. Yeah, I found the data dictionary to be the only way that I could understand this data because it's 470 plus columns and everything's encoded. And so I spent like the first couple weeks before the program just organizing and inventorying with Dr. Adams everything that we actually had. And I love that solution to the changing questions over years. We started a document like that where, because programmatically, if you organize it all in a table and you have the questions that change, the variable from 2014, the new question, the variable from 2016, it's very easy to make like a lookup table. And so we're definitely going that route. I was very surprised that nobody had developed a solution to this problem yet. I looked all over the internet. I did a lot of research. I emailed the CDC, which is crazy because there's so many papers using the data. Why has nobody kind of done this sorting algorithm already? If there's time, I would love to do that.
Well, it's because we were waiting for you.
You're waiting. I did have a hunch that it would be in SAS because the CDC loves SAS files, but I went through the SAS code and I didn't see a whole lot on this topic. So maybe if we have time.
Yeah, it's also just an artifact of the field. You know, we go through so much pain trying to resolve that by the time you're done resolving that, you're just so crunched for time and getting your deliverable and paper out. You just solve that problem and you're like, whew, I'm done. But you never share it with the field because, I always tell people in healthcare and healthcare research, what is common to the field of data engineering, where we have GitHub and other sharing things, it's not common to us. We don't just go put our codes everywhere and things everywhere. That's something we're just still learning to do. So it's not common, which is again why I say, if you do that on the other side, my goodness, the field will love you for it. And you would just be a rave review and someone they're talking about all true because we all go through this problem.
I'm glad to hear that. I'll keep it in mind and I'll try and do it.
Well, I apologize. I'm going to have to go wait so I don't miss my flight. Dr. Adams, thank you so much for what you always do. I was bragging about you on my way driving Charmaine to the airport and saying, we've got mentors and then we've got Dr. Adams. so
Yeah.
appreciate that.
She'll see that in the recording.
Yes.
Okay.
We'll
All right.
see.
Well, you guys, yeah, I'm hopefully gonna make it through sitting straight for 16 hours, but hopefully I won't grouch you when I arrive.
Are you gonna be meeting up with Dr. Oh shoot, it slips me. Literally, Dr. Rafielway. How could I forget?
Yes, she's one of the hosts and one of the reasons why we're going there. So we're gonna meet with her. We're gonna meet with the University of Johannesburg. We're gonna meet with the NIH version in South Africa. We're gonna meet with a research council. We've got, I mean, they just lined everything up. I'm now terrified because they only said we'll meet with 2 groups before, but now it's down to like 6. But that's okay. I got 16 hours to create PowerPoints to present to them.
Well, good. I hope you have fun there and tell her that she is dearly missed in the US and I'm still looking for her muffins.
And all of you have a wonderful weekend. I'll be in touch with emails and information. And by the way, because I was thinking about Hunter's Day and Hunter